Hello. Good morning, everyone. Welcome back to our TGMET International Workshop 2021, the unprecedented view of complex laparoscopic surgery, in-depth surgical video presentation. And today we have plenty of things to share with you. So first topic will be presented by our legendary Professor Masaki Ando, and then followed by the live surgical demonstration. And in the afternoon, we'll have more interesting topics about the laparoscopic pelvic floor reconstruction. And at the very ending topic will be about the in-back morcellation. In this topic, we'll present you the tips and tricks in doing the in-back morcellation with our economical and efficient TGMET bag. Okay. So before we move on to the first session, let me introduce my co-chair, Associate Professor Pawit Sucharit-Pong. Okay, so now due to time constraint, so we're gonna move on to the first topic presented by Associate Professor Masaki Ando, the laparoscopic ureteral reconstruction for ureteral injury, recurrent cancer, and deep infiltrative endometriosis, sponsored by Takeda.
Good morning, Professor.
Good morning.
Good morning.
We need to open the video for our sponsor.
I'm sorry, yesterday the video didn't move smoothly.
Oh, okay.
I didn't notice it. And I suppose every audience feel a lot of stress. Today I a little bit combated, and I prepared two PowerPoint. Okay. I talk about the laparoscopic ureteral reconstruction for ureteral injury and after radical resection of the ureter for recurrent cancer and DIE. What was our trigger? We started the laparoscopic reconstruction to make our surgical environment safer. Ureteral injury was our first experience and encouraged us to learn the management of the urinary tract injuries. This case was my first urinary tract reconstruction case. It was in 1999. It was the result of accidental injury during the laparoscopic radical hysterectomy. While unroofing of the ureter, I inadvertently transected. And that was how it all started. And this is our basic ureteral neocystostomy technique. After resection of the involved part, the cut end of the ureter is implanted into the bladder. In this case, I performed the laparoscopic ureteral transplantation under supervision of the urologist for the first time. Intracorporeal suturing demands precise controllable instrument, meaning good hand-eye coordination with both hands and ability to maneuver very small needles. Ureteral neocystostomy was performed extravasically laparoscopically. After this experience, I decided we need to expand our skills for reconstruction. We trained to perform ureteral neocystostomy and applied this to the ureteral endometriosis and recurrent gynecologic cancer. Expanding our reconstructive skills showed us to expand the scope of surgery. Intracorporeal suturing requires advanced skills. For this technique, we need intracorporeal suturing and ligation training. By adopting this training, we were able to extend the scope of our surgery and introduce injury repair and reconstruction technique into our surgery. This is a real uterine endometriosis case. The ureter below the pathologic segment was transected. Then the involved segment was removed. Then the reconstruction started. Usually we perform uterine transplantation extravasically. It's easier to perform. I also introduced the robotics techniques of ureteroneocystostomy. Yesterday, Alan Lam demonstrated the severe endometriosis case. We performed the laparoscopic ureteroneocystostomy maybe over 90 cases, and experience in robotics is low. But I feel the low-tech laparoscopy is more comfortable. Robotics bring the dexterity, precision, and reproducibility to the surgical environment. But during extensive dissection, no tactile sensation. My one concern to make excessive pressure to the end of the ureter. From now on, I will move to the uterine endometriosis case. Could you raise the volume of the narration? Do you hear the sound? Pattaya,
Prof?
can you hear the narration?
Yes, Prof.
Yes, clearly.
Yeah.
Clearly, okay.
Clearly.
Except that the video sometimes is working, sometimes it's not working.
Unfortunately. なんと続きがどうなってんのかな。視線を
กลับไม่ได้
Pattaya, I'd like to reconfirm. The slide is already narrated. Can you hear the narration of the slide?
Very, very low volume.
Can you raise the volume there?
Let
ไอ้
me,
สไลด์ที่เขาเปิดจากของเขาป่ะเรา
we cannot control the volume from here. I think it's from the origin.
We performed more than 90 cases. Only one leak was found. How about this video?
Yeah, you have to, yes, now it's working. But we cannot hear the sound. So you might have to help us.
I'll explain then.
Yeah.
This is bladder endometriosis cases. The uterine cervix is attached to bladder severely. And the first step is dissection of the bladder. Now we open the pre-vesical space. And under the assistance of the urologist by cystoscopy, we decide the cut line. Because of the volume tumor, the volume of the bladder decreased. After discoid resection, we close the bladder, but the right ureter is very near to the tumor. So we decided to reconstruct the ureter. After retrieval of the tumor, we started extravesical uterine implantation. What about the quality of the video? Does video move through smoothly?
It's kind of jerking a little bit, but it's still according to each step, so we can understand. So like it comes in like in
Okay,
short
maybe
after short.
I have to change the file to the movie, converted movie from the PowerPoint, from the next slide.
Okay, and if you want to get the sound to work, you might have to go to the setting, the audio setting of the Zoom.
More severe case, the right ureter is severe stenosis just around the right parametrium. The ureteral dissection proceeds until the physical ureteral junction is reached. And mobilization of the ureter is important. So we dissect the ureter up until the cross point of the common iliac artery. Now we dissect the bladder and mobilize the bladder cephalon. The double-jet stent is removed, and the caudal end is ligated. Now we expose the psoas fascia, and the bladder is mobilized to the fascia. This compensative technique is applied depends on the size of the defect of the ureter. Now the bladder flap is suture fixed to the psoas fascia. Dissects the mucosa for creation of the submucosal tunnel. It prevents vesical ureteral regurgitation. The tip of the ureteral end is suture fixed to the detrusor muscle. Then double jet stent is placed laparoscopically. So, 動画に変えます。さっきコピーしておこう。1の終わりぐらいから。This is intrinsic type uterine endometriosis. This case suffers from the bladder endometriosis and also the uterine endometriosis. So we performed the discoid resection of the bladder endometriosis along with the lower part of the ureter. Okay, can I have a time to change the file?
Yeah, while we're waiting for, are you okay now, Prof? So while we're waiting for Prof Ando a video, I'd like to ask you whether you Dr. Pawit, whether you have any experience about ureteral involvement of endometriosis.
Yeah, I have lots of cases and maybe 3 cases that we invite Dr. Ando to come here and he operate my case about 3 ureteral endometriosis and he did the reimplantation for my case and all 3 cases went very well, no problem.
So how would we choose, like which one will be just like a simple reimplantation, or which one we will use so as hitch, something like that?
It depends on the length of the ureter that left. If it's long enough, you can reimplant, but if not, you can have to mobilize the bladder and have the psoas hitch or body flap or something like that.
Oh, okay. Okay, now I think Prof is ready. So now we can come back to his video.
Hello, Professor.
Oh, how was the video?
It's
the
okay.
movement is much
That's
good.
better now.
better.
Yeah, they are smooth now.
Okay. But unfortunately, the narration is not on. Could you raise the volume?
Oh, it's come from your
source?
Zoom.
Yeah.
You have to put the voice on your Zoom. It's not we cannot manage your video voice.
You can hear the sound, right?
It's your sound, but not the video.
Okay. So I have to talk.
Yeah, yeah.
So this case is I performed in the Japanese one university to ask to perform ureteral cystostomy of the severe endometriosis. The technique is the same. The dissection of the ureter and this is just a source pitch. The next one, if the defect become larger, we have two other techniques. Actually, the most difficult part is not reconstruction, the mobilization of the bladder. Like this, a lot of fibrotic tissue is surrounding the ureter. And now we dissect the pre-vesical space to mobilize the bladder separate. Saturated to prevent postoperative stenosis. The bladder inside. Okay, this is also the body flap case. The concept is create a duct from the bladder. This transvesical transplantation is, implantation is much more complicated than extravesical simple ureteral cystostomy. The important point is tension-free anastomosis and torsion-free at the anastomotic site, and also perfusion of the anastomotic site. Yeah, this is the intrinsic time uterine endometriosis. This is the biggest defect. So the segment of the ileum is interposed between the bladder and the ureter. This case suffered from the recurrent endometrial cancer, and the tumor recurred at the right parametrium. So dissecting the ureter at the parametrium is a danger to scatter the tumor cell. So we decided removal of the parametrium and the vagina and part of the bladder. So in this case, the body flap is impossible because the reduced size of the bladder. So the segment of the ileum is interposed between the ureter and the bladder. This is a postoperative finding, cystoscopic finding after 3 months.
face.
อยู่โอตะ
Yeah, I can see Dr. Ota is operating. Now the boss is in the theater to solve everything out.
we not hear anything, Professor.
So what's the plan now when the boss arrives?
I rushed the operative theater as soon as possible. And
So now you're checking the length of the ureter?
this is even for me, it's a shocking big size defect. 3 or 4 centimeter ureter defect.
Oh, okay. So the ureter has been cut distally, about 4 centimeter.
He removed the segment of the ureter actually.
Yeah, we saw it.
So you've checked that there's still tension, right? When even you mobilize after mobilization of the bladder.
Right, exactly. The ureter is too short to direct the implantation. So again, we decided to body flap and psoas hitch.
So the reason for psoas hitch is to fix that bladder with the psoas so that there's no tension on the joint area, right?
Right. The tension-free anastomosis is the most important. The point of tension-free anastomosis is full mobilization of the ureter and the bladder. But even the defect exists, we need some other techniques like body flap or psoas hitch. The first layer is closed. This is the mucosal layer. The second layer is approximation of the detrusor muscle. Full layer detrusor muscle is approximated. I skipped one. Then I already.
Substitution.
This case is suffered from the recurrent cervical cancer. The involvement is right parametry and right ovary and ureter. So we performed radical parametrectomy with resection of the lower part of the ureter. Now, internal iliac artery was ligated and cut. We dissect the right parametry at the pelvic side wall. Now we start development of the pre-vesical space. This case also required a Boali flap and a psoas hitch, and because of the large defect of the ureter. Boali flap is suture fixed. Usually we use the 3 sutures here.
Then the opening of the bladder is closed in 2 layers.
Video voice, Professor. Now,
Yes.
we can hear the voice of the video now.
Yeah, okay.
The stump of the ureter is spatulated to prevent stenosis at the anastomotic site. The stump is introduced into the tunnel using traction suture. And the ureter is suture fixed to the newly created ureteral orifice. Tension-free anastomosis is of paramount importance. Now we introduced a WJ stent into the ureter. We have developed our own placement method that doesn't require cystoscopy
placing the
or
WJ
urologist.
stent.
The
We can
WJ
perform
stent is placed laparoscopically.
the first
The
layer is
opening of the bladder is closed in 2
bladder
layers.
mucosa. The second layer is the petrosal muscle.
The specimen is extracted using a double protection bag to prevent contamination. The Boali flap and psoas hitch was successful and the patient recovered quickly without complications. The second case suffered from a recurrent tumor at the right parametrium near the ureter after simple
I
history
already
for
told
early
I
stage endometriosis.
skip this.
And needs to be had process of the graft performed successfully.
Let me talk about some complicated cases. Sometimes a patient suffers from both rectal and ureteral endometriosis. Although rare, sometimes rectal and ureteral endometriosis occurs at the same time.
Sometimes the patient suffers from both ureteral and rectal endometriosis. We experienced around 10 cases in my series.
Laparoscopic surgery for extensive endometriosis is one of the most technically demanding procedures. In extreme cases, reconstructive surgery is required after excision of a severely affected site. Donay and colleagues describe three different forms of endometriosis. Also rare, deeply infiltrate endometriosis also could attack the rectus sigmoid and ureter. Involvement of the ureter and bowel with endometriosis relatively uncommon. Around 1% of cases require reconstructive surgery. Rectus sigmoid endometriosis is most common intestinal endometriosis. It accounts for over 80%. The small bowel for only 5%. Deeply infiltrated endometriosis may invade deep into the musculature of the rectus sigmoid colon. Bleeding, obstruction, and transition to malignancy are all possibilities. Although rare, ureteral endometriosis can also cause serious complications such as stenosis and obstruction. 20% of ureteral endometriosis infects the full thickness of the ureteral wall, called intrinsic disease, affecting the muscularis or lumen. As 50% of the patients are asymptomatic, sometimes it leads to silent loss of renal function. In such severe stenosis cases, segmental resection and reconstructive procedure is required. Laparoscopic management of rectal endometriosis is shown here. A double stapling technique is used for reconstruction. The vagina is used as a route of retrieval of the proximal stump and application of the ampoule. After resection of the involved segment, the rectus sigmoid is reconstructed by double stapling technique using both linear and circular stapler. The video shows the reanastomosis of the rectum using circular stapler. This technique is performed totally laparoscopically. This is the ureteral endometriosis case. The ureter below the pathologic segment was transected. Then the involved segment was then removed. The urinary tract is reconstructed by an extravesical uterine implant to the bladder. Anti-reflux valve is created by making submucosal tunnel. A case which we experienced last year is presented. The case suffered from both rectal and ureteral endometriosis. We started from isolation of anatomical structures. The first step is separation of the rectum from the cervix. On the course of dissection, a very hard fibrotic mass was encountered which surrounded the ureter. After separation of the uterine attachment, the vagina was incised. Then the uterus was retrieved through the vagina.
He's about to finish it.
When dealing with difficult endometriosis, all surgeons encounter
5 cm from the tumor up vagina and transect the segment and place the ampoule outside the body. Then the rectum is reconstructed using circular stapler. Now the dissection of the rectum is started. The mesorectum is dissected. The involved segment of the rectum was transected using a linear stapler at a level of 5 cm from the tumor lowest margin. Then the rectal stump on the anal side was extracted outside the body through the vagina. The oral side of the involved segment was transected. Surgical clearance of more than 5 cm from the tumor upper margin is desirable to prevent recurrence. An ampoule is inserted in the rectal stump and fixed with the aid of the purse-string suture. After the rectal stump is carried into the abdominal cavity, the rectum is reconstructed using circular stapler. Now the stapler is fired and the rectal anastomosis is completed. The integrity of the anastomosis is confirmed by checking the donut shape of the specimen and also by air leak test. Now we start the procedure on the urinary tract. The first step is opening the prevesical space. The purpose of this procedure is mobilization of the bladder for creation of body flap. Tension-free anastomosis is of paramount importance for successful reconstruction. The ureter is transected below the involved segment. Fibrotic tissue around the ureter is removed. The vaginal opening is closed with the intercorporal continuous suturing. The body flap method is an effective option for bridging larger lower uterine defects when tension would still exist after anastomosis. To enhance the extension of the bladder, the body flap duct is hitched to the psoas tendon. We resect the involved segment of the ureter and the specimen was retrieved. Now the specimen is shown. We need reconstruction of the urinary tract. Because of the relatively large urethral defect, we decided to use the Boari flap method. The bladder wall was incised in a boomerang shape. The bladder was extended in the direction of the psoas muscle, then the edge of the flap was fixed to the psoas tendon by intercostal suturing. 2 or 3 sutures are required for fixation. As a result, tension-free anastomosis of the ureter into the bladder became possible. The stump of the ureter was spatulated to prevent postoperative stenosis. After creation of the submucosal tunnel, the ureteral stump is anastomosed to the bladder duct created by this flap. The bladder mucosa was undermined to create a submucosal tunnel. The ureter is passed beneath the tunnel, and the orifice of the stump is suture fixed to the inner aspect of the mucosa, as well as the detrusor muscle of the bladder, resulting in the creation of a new ureteral orifice. The opening of the bladder is reapproximated in 2 layers using synthetic suture. Continuous 3-0 suture in the first layer and 2-0 interrupted suture is used in the second layer. Before complete closure of the bladder, a WJ stent is placed laparoscopically. We developed our own technique to place WJ stent laparoscopically. It is possible to insert without the use of cystoscopy and without the help of the urologist. Traditionally, this kind of surgery is very invasive, thus elevating intercooperative stapling and suturing skills expands applicability of laparoscopy to even the very complicated procedures while keeping surgery minimally invasive.
Success in laparoscopic surgery depends on these issues, knowledge of the anatomy and skill to cover.
Knowledge of anatomy and skills to cover the defect to the ureter and bowel after extensive resection. Training oneself in suturing and other instrument manipulation skills that are vital in the laparoscopic environment. Knowledge of energy devices and other equipment necessary in laparoscopic surgery.
Thank
you very much.
Paramount importance is ureteral tension as anastomotic site and avoid the torsion as anastomotic site and maintain the perfusion around the ureter. Okay, thank you very much.
Thank you very much,
Thank you very much,
Professor.
Prof. I've got one question. Since I'm a urogyne, so I kind of wonder, whether after the reconstruction of the bladder, after reimplantation of the ureter, it seems like the bladder doesn't look the same. It has a different shape. So would that affect lower urinary tract symptoms? Whether patient's gonna empty the bladder completely, or the detrusor muscles of the bladder is gonna work properly like before the injury?
So far, we have performed more than 90 cases, and in some cases, it suffers from basic ureteral regurgitation. But sometimes infection, like PLETs occur, but it's not a big problem so far. And bladder habit is not changed. At least no complaint about urination problem. And only one case suffers from the leak at the anastomotic site. But this case is special because this case suffers from both rectal and ureteral endometriosis. And unfortunately, it was a leak from the rectal anastomosis, and the patient suffered from acute peritonitis. in such situation, the urethral implantation is failed because of the infection problem.
And,
Only one, only
I'm
one
sorry.
case we need a reoperation.
Prof, in advanced, very extensive dissection like this and repair the bladder, the ureter, can we put the anti-adhesive agent at the end, or we shouldn't put?
You mean the after aging?
The anti-adhesive agent. We were afraid of the
Oh,
adhesion.
sorry. I misunderstood. I don't usually use anti-adhesive agent previously because I performed this from 1999.
Oh, okay.
At that time, there's no good variation and adhesion barriers. So recently, I use adhesion barrier, but maybe more than 70% is we didn't use the adhesion barrier. But no case suffer from ileus, so the small bowel obstruction.
So there's no contraindication, right? Even after you repair, you can put that. You can put that to prevent the adhesions. Okay.
Fortunately, we didn't experience a lot of symptomatic adhesion cases. Probably the hemostasis is have a big effect about the adhesion, and we usually concentrate on complete hemostasis. And sorry, and what another problem is I forgot.
Well, yesterday I listened to Professor Tinnebag about bowel resection in endometriosis, and he said that once you do the bowel resection, it's like he tried to avoid putting the anti-adhesion agent because it could induce a leakage. Risk of leakage at the anastomosis site. So I'm not sure if what about the bladder when you repair it? Can you put that agent?
Around 30 cases in total, I use anti-adhesive agent, but no case suffers from leak. Only one case, the leak is, as I said, peritonitis case. Yeah, infection have a big effect about the leak for the urethral implantation.
Okay. And any question from you, Dr. Pavit?
You have done about 3 of my case that urethral reimplantation, but every case went very well here in Thailand, Professor.
Fortunately, in my institute is not big and no big wall between the urologist and the gynecologist. And
yeah.
And if I refer to the urologist, they open.
Yeah,
So
here too.
yeah, so original minimally invasive purpose is impaired. So I perform urethral implantation, but cooperatively to the urologist, because after operation the examination is performed by urologists like CT or some regurgitation test.
Yeah, we have the same problems.
Yeah,
our urologists, they prefer open surgery.
Yeah.
Yeah, but our patients, they don't accept that very well. Okay, we're kind of ahead of time. So any questions from the floor?
Any question?
Professor Pongsak. I think we've got one question from Professor Pongsak.
Good morning, Professor Masaki.
Morning, Pongsak.
Every time that I watch your video and your presentation, it really hit my heart. And sometimes I think my heart will fail because you did a very sophisticated operation.
Exciting.
Every time that you perform the urethral implantation, it's very good result that I have seen every time. And I think you are the only one surgeon, gynecologic surgeon, that perform this kind of urology very good. So I think you,
Oh, thank you very
you
much.
have both gynecologist and urologist in the same time. So I really appreciate that.
Yeah,
And
he's such a multi-talented.
When I watch your video today, it has some progression that you put the two rare suture with different stitch. So I think it's very good to prevent leakage from my opinion. So thank you very much. No any comment or no question for you because you are really great surgeon. Thank you very much.
Yeah, he's so good
No,
that we're out of
actually.
question.
You did
Okay,
one
anyway,
great.
thank you very much. Okay.
Okay, thank you very
Thank you very much.
Arigato.
Okay.
Hope to see you next year, Professor.
Okay, well,
Bye bye.
we'll see you. Bye-bye.
See you soon.
See you soon.